Assalamu alaikum, everyone. All right, beliefs are the hidden script that runs our life. And you know what's an open script? These are the researches which can change our beliefs. So today's topic of my presentation is comparison of an outcome of an intracranial aneurysm surgery with and without the proximal control. So before I start with my presentation, do we know that 5 million innocent people on the face of Earth, they lost their life on every calendar year with aneurysm. On an every 18 minutes on a clock, a single aneurysm gets ruptured. 4 out of 7 patients with an aneurysm live a life of a disability after its rupture. There are literatures which are full of educating, taking a proximal control before the surgery. But at the same time, there's a battery of researches which shows that we can operate without taking a proximal control. There's one review of literature in which Mr. Chris operated on 292 patients. 50 of them were taken for proximal control and 50% of them were without the proximal control. 29% of them shows post-ischemic changes, and 34% of them have a vasospasm. On top of it, there are 48% of the patients which were later on followed up with the pseudoaneurysms at the place of temporary aneurysmal clip. So talking about temporary aneurysmal clip, when we observed a tray of clips, which temporary aneurysmal clip usually shows in a golden color, but what does it make difference from a permanent clip? It's not only its color, but the force that it apply for an occlusion of an artery, which is half than the permanent clips. So in our CASI study, we have took 82 patients, and duration of our study was 9 months, and we will follow up each patient for 3 months. In our follow-up post-operatively, we have a CT scan plan after 72 hours, as well as we followed patient neurologically and CT angio after 3 months. So there was 82 patients with a mean age of 45. They were predominantly female, and we had 2 groups. In one group, there was temporary clip applied, and in group B, temporary clip was not applied. And the number of participants among 82 was 25, in which temporary clip was applied. Before I proceed further, here in our outcome, we'll talk about post of an ischemia in patient, number 1. Number 2, we'll talk about the time of temporary clipping, which will lead to the post of an ischemia, and the age of the patient, which make them vulnerable for post of an ischemia with temporary clipping, and then the combination of an age and the time of the clipping. Over here, the histogram shows that the subarachnoid hemorrhage duration at the time of surgery was almost an average 18 days when we have performed surgeries on this patient. So location of aneurysm was most common ACOM, then followed by an MC aneurysm. Time of an obstruction for group A, in which we have applied for temporary clip, was more or less 8 minutes with a few seconds. The minimum was 5 minutes and the maximum was 15. The duration of temporary obstruction, the 91% patients were less than 10 minutes, and then the rest, 8% was more than 10 minutes. Ischemic changes. Post-operatively, when we have followed patient in the group in which we have applied a temporary clip, there was a good amount, 40% of them have suffered with the post of ischemia. Rather, in the group B, in which we haven't applied a temporary clip, there was only 24% of them who have suffered with an ischemia. If we compare both groups and their age of the patient in those groups, the patient in group A in which the clip was applied and the age was more than 50.
1 minute remaining.
77% of them suffered an ischemia. And in group B, in which the clip was not applied and age was 50, 43% of them suffered ischemia. That means the age also correlates with an ischemic changes postoperatively. This is the same slide. So this is a picture of an angiogram which shows temporary clip at an ACOM as well as a vasospasm at the arrows. So what was our result? Of the patient who underwent temporary clipping, a significant association with an ischemic changes. Temporary clipping longer than an occlusion time of 10 minutes was significantly associated with ischemia. Patient with an age 50 years, greater than 50 years, shows statistically significant association with vasospasm. Well, our conclusion over here is temporary clipping when employed appears to be beneficial and has a significant impact on clinically vasospasm. Avoiding longer duration of temporary clipping in patients with an advancing age would decrease the frequency of postoperative ischemia. What would be our recommendation over here? For young neurosurgeons, they may use proximal control for aneurysmal clipping, but for experienced neurosurgeon, we will recommend them to don't use proximal clip for aneurysmal clipping. Older patients are more liable to ischemia, so proximal clipping would be more harmful for them. Thank you.